Good morning and good afternoon, everybody who's joining us. I'm Grace Rubenstein with HealthBegins, and I want to thank you so much for joining us at HealthBegins along with AcademyHealth and the Southern Jamaica Plain Health Center on this webinar, which is entitled Equity and Structural Racism, Challenges and Opportunities for Healthcare. We've seen incredible interest in this subject. It's broken all of our previous webinar records, so we're really pleased to have such special guests joining us today to share insights with you on this subject, ranging from policy to practice. Before we start, I want to just let you know a couple of things. First of all, this webinar is being recorded, and we'll be sending out the recording to all registrants after the webinar. Also, all of the lines for participants are on mute, but we really want to hear your questions. The way you can do that is to type your questions into the questions section, which you'll see on the panel at the right-hand side of your screen. And we've reserved a good chunk of time at the end to go through those questions, but you can enter them into the questions box at any time. This presentation is scheduled to last for 1 hour. And with that housekeeping all out of the way, I'm going to hand it over to HealthBegins President Rishi Manchanda, who is our host for today. Rishi?
Thank you so much, Grace, and thanks to all of you for joining today for, I think, both a timely and incredibly important conversation. Thanks also to our co-presenters today, Margot, Tom, Juan Jaime. You'll hear from them shortly. I wanted to spend a few moments giving some orientation to today's conversation. First, recapping the learning objectives that we had shared in the initial invitation that was sent out to all of you. By the end of this webinar, we hope that each of you will be able to first describe how equity and structural racism relate to current efforts in health and healthcare to advance the social determinants of health. Secondly, we're hoping that by the end of this webinar, attendees will be able to describe initiatives that healthcare institutions and researchers are using to advance structural justice and health equity, especially when it comes to structural racism. And last but not least, we hope that attendees will walk away from today's webinar with concrete ways, at least 3 ways, that you can use to align your institution's social determinants of health strategy and your diversity and inclusion efforts to better address structural racism and equity. So with those learning objectives in mind, a brief background on HealthBegins for those who are unfamiliar with us. HealthBegins is an organization that was founded in 2012, became a full-time endeavor for members of our team a little over a year ago. Most of what we do is work at the intersection of clinical and community partnerships with the hopes that we can leverage our quality improvement approaches, our community partnerships expertise, and our social determinants know-how to be able to improve care and broader social determinants of health. What we've learned in this process is that this conversation about equity and structural racism is incredibly interrelated and foundational to any meaningful conversations around social determinants of health. At a time when more and more healthcare institutions in particular, but broad stakeholders, and not just healthcare, but in public health and other place-based initiatives, are focusing in on social determinants of health, are asking important questions about value, looking at ways to better manage and improve population health, better opportunities to advance the triple aim, if not the quadruple aim. In the midst of all these important conversations, one of the important questions that we were hoping to explore today together with our co-presenters and with each of you is the degree to which these approaches are grounded in an understanding, if not in a framework, to address structural racism and equity. The reason I share this picture is to help ground us in the story of a person. This is a picture of a young woman. She died at the age of 27. She died just before New Year's on 2017, so December 30th of 2017, a little over a year ago, a little less than a year ago, excuse me. And she died 4 months after delivering her son. She died out of complications of an enlarged heart that was not well treated through her healthcare system. She had chronic underlying asthma that exacerbated and then led to the subsequent heart attack. Her name is Erica Garner. She was the daughter of Eric Garner, who is a gentleman who died in a police chokehold in New York City in 2014. She named her son, the grandson of Eric Garner, after her father. So she left behind children, including her son at the age of 27 when she died. From the current perspective of social determinants of health, when healthcare institutions look at the story of Erica Garner, it's very likely that in the current context, healthcare institutions will be more open to talking about the social determinants of health that may have predisposed her to having this tragic outcome, a asthma exacerbation that resulted in a heart attack and an untimely death at the age of 27. The social determinants of health that went into that contributed to her now becoming a tragic statistic of the maternal mortality disparities that we're seeing, especially among African American women. What is important about her story in particular and compelling for me and for I think many of us as we think about her story is that Erica Garner was to her dying day a champion for racial justice and equity, especially based on and compelled by the story of her father's death due to police violence and brutality. Erica was fighting a fight against structural racism, institutional racism, interpersonal racism. And as healthcare systems grapple with how to address social determinants of health, the question that I think Erica's story presents to us is whether that's sufficient, whether a social determinants of health analysis devoid of a structural racism understanding is going to be able to truly get us to not only treat but prevent deaths like hers. So with Erica Garner as our moral kind of anchor point for today's conversation, I wanted to let you know where this particular conversation started earlier this year. So about 6 weeks after Erica Garner's death, our friends at AcademyHealth, including Margot Edmonds, who you'll hear from in a moment, hosted a conversation at the National Health Policy Conference. I had the privilege of being a panelist along with Trish Torres from the Institute for Healthcare Improvement, along with Bob Ross, the president and CEO of the California Endowment. And Bob Ross had just given a rousing keynote in which he addressed issues of structural racism, of equity, especially as they impacted youth and men of color, and the nexus of structural racism and gun violence. It was a compelling, rousing keynote that spoke to structural racism. And on this panel, we started to realize that there were some intersections that were currently not evident, intersections between the social determinants of health space and those working on diversity and inclusion, and those who are advocating for greater structural solutions to address structural racism. So what emerged out of these conversations in the National Health Policy Conference then led to a series of conversations at AcademyHealth a few months ago in June at their meeting in Seattle. Subsequent conversations with friends at the Southern Jamaica Plain Health Center, who you'll hear from in a moment, and led us to today. And what today really represents is one now in a series of conversations, and we're so pleased that you've joined us with it. So I mentioned several times structural racism. The purpose of today is to deepen our understanding of what this may mean, explore challenges and opportunities for healthcare systems as we think about our roles in addressing structural racism vis-a-vis our social determinant strategy and our diversity inclusion strategies. This is a particularly salient quote to help ground our conversation. Despite growing interest in understanding how social factors drive poor health outcomes, many, including academics, policymakers, and so on, remain reluctant to identify racism as a root cause of racial health inequities. This is a quote from an article that came out in The Lancet titled Structural Racism and Health Inequities in the USA. It's a highly worthwhile read if you haven't already reviewed it yourself. The citation is at the bottom of the slide. We present this as a problem statement. Is it true in our experience collectively for those on the call and those who are going to look at this webinar in the future, is it true that in the current moment, while we increase our understanding of social factors and their role in driving poor health outcomes, that we have remained reluctant to address, if not identify, racism as a root cause? This is, in some ways, a problem statement that's organizing us today. And we wanted to at least see if this is a shared set of assumptions, understand your context, by starting off with the initial poll. So the first poll for today is this question. Among the following areas of work in your own institution or organization, where do you specifically spend the most time? Do you spend the most of your time working on improving social determinants of health? Are you engaged predominantly in diversity and inclusion efforts, serving on committees and other initiatives related to diversity and inclusion? Is most of your time spent in quality or performance improvement activities? Or are you mostly in policy and advocacy? Or are you involved in direct clinical care? If you're an executive, we imagine that you're spreading your work across all of these domains, and so pick the one that you think most aligns. Let's give it another 10 seconds. Please select one. Let's go ahead and close the poll. Seems like a good third of you actually are self-identifying as spending most of your time these days on the social determinants of health side of the spectrum. A good quarter are spending their time predominantly in quality and performance improvement. About a little less than 10% in diversity and inclusion predominantly, and others in policy and advocacy, with an equal balance between that, roughly equal between that and clinical care. So a really interesting kind of spread of experiences. Let's move on to the next poll question to further understand who we have collectively on the call today. To really understand, depending on where you self-identified, how aligned your work is within your institution. So wearing the hat that we just asked you to wear, whether you're predominantly in one of those, regardless of which one of those circles you're in, let's ask you how well aligned you believe these work streams are in your institution. So the next poll question will explore your own perception of alignment in your institution's work across those 4 different domains. So let's launch the poll. How aligned are your institution's approaches to social determinants of health and diversity and inclusion specifically? Understanding the hats that you wear, do you feel like your institutions have no formal processes or structures to address social determinants of health? And by formal structures or processes, we mean things like organizational strategies, departments, committees, teams that have been formally recognized and chartered to address social determinants of health or diversity and inclusion. If you don't have them, select the first answer. And if you feel like they're not aligned, you do have them, but they're not aligned, answer accordingly. If they're somewhat aligned, if they're well aligned, and if you're not sure, of course, please select there. Another few seconds. All right. So almost half of about 4 out of 10 believe that your social determinants of health and diversity inclusion approaches are somewhat aligned. 9% believe that they're well aligned, and it looks like collectively about 36% of folks either have no formal structures or processes to address both social determinants of health or diversity inclusion, or have them but they're not aligned. So now that we understand where we are in the context, let's spend a little bit more time actually understanding what this term means. Structural racism, in the way that we're orienting ourselves for today's conversation, and what you're going to hear our presenters discuss, is defined in slightly different ways, but this is one definition that we pose to the audience today. It is the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, criminal justice. And these patterns and practices in turn reinforce discriminatory beliefs, values, and distribution of resources. Structural racism is a distinct concept and area of work from institutional racism, which is in some ways a component of structural racism. Institutional racism refers specifically to discriminatory policies and practices that are carried out within and between individual institutions on the basis of racialized group membership, as Nancy Krieger and others have defined. And then there's, of course, then a component of individual and personal racism as well, which is the prejudgment, bias, or discrimination based on race that individuals exact on each other. This is a taxonomy that we wanted to present for today's conversation, and really start to engage in a conversation that takes those hats that each of us identified wearing at the top of the call, whether you're predominantly in the social determinants of health hat, the diversity inclusion, or the quality improvement space, or even an advocacy hat, and wonder about, as those work streams are trying to align, to what extent are your work streams right now in those 4 areas based upon an operational framework that addresses structural racism and equity. And in today's conversation, we're going to actually go headlong into that really, again, timely, complex, and important conversation right now with a few framing questions. The presenters will speak to many of their areas of work, but in particular, listen for how they answer these questions. First, how is social determinants of health and diversity and inclusion work done differently when it's based in a framework that addresses structural racism and equity? This is a question for our presenters as well as for each of us. Secondly, where are health and healthcare institutions getting stuck when it comes to aligning and advancing diversity, inclusion, and social determinants of health efforts? And lastly, what are the concrete ideas or innovative ways that that our presenters are going to share and that each of you have to offer for ways that healthcare institutions in particular can get unstuck to really move the needle on improving structural equity and justice? So with those framing questions in mind, I will now pass the baton over to our first presenters, Tom and Juan Jaime from the Southern Jamaica Plain Health Center, who will now introduce themselves. Tom?
Thank you, Rishi. I'm Tom Kiefer. I'm the Executive Director at Southern Jamaica Plain Health Center in Boston. My colleague Juan Jaime and I are honored to be able to presenting on a topic that's so important to us. You want to say who you are, Juan Jaime?
Juan Jaime de Sengotita. I'm the Medical Director here at Southern Jamaica Plain Health Center.
Since we'll be talking about addressing racism in the presentation, just want to share my identity as a white man, also as someone that's been connected to community health centers for more than 40 years as a provider and administrator. And to say that health centers have traditionally addressed social determinants much more than other parts of the healthcare system, but we are really just starting to do systematic screening for social determinants of health like many people across the country. And what we're presenting today is not a system to do that that we have perfected, but rather it's an approach and a way of thinking that reflects our experience. So hopefully it will contribute to the conversation at your organization, to our conversation together. I want to start with an example that's really addressing the first question head on about how social determinants of health work is different with a structural racism or racial equity framework. So on the screen you have this is the traditional framework. The patient is needy, the patient can't get to their appointments, the patient needs to be fixed. And the traditional solution, we're going to find a temporary solution for the patient, a downstream solution, get them a cab voucher or a lift, or help them apply to Medicaid for transportation benefits. And that's going to be the extent of the approach with the traditional way we think about patients. Next slide. So here's a different framework, a racial justice framework, or a framework that puts structural racism kind of at the heart of how we look at the world. So in this framework, the patient is not the problem, the system is the problem. The slide here shows the redlining map in Boston from 1938, almost 80 years ago. And because this is a transportation example, even though this is a mortgage slide, the interconnection of all these elements that are involved in structural racism is really at the heart of this. So the same neighborhoods that were racially redlined for mortgages are now ones suffering from transportation problems. In our part of Massachusetts, the transportation, more transportation dollars are spent relatively for commuter rail riders, suburban, mostly white riders coming into the city, compared to the bus system, which is largely used by people of color in the city. It doesn't get its share of funding. It's not a very good system, and it's a problem for many of our patients. Next, Rishi. So the transportation inequities that we see and that we're thinking of to begin this process are really closely linked to historical processes that relate to housing, mortgage, as I said, jobs, wealth, and all these other social factors. Next slide. Let's keep going, Ishi. Yeah, so here you see on the right the adult diabetes by subway stop in Boston. And it's hard for you to really align the two maps. But I can tell you that the part that's red on the left, which is Roxbury, does not have a train stop. It's served by buses. If you overlaid these, you'd see that the historical problems of disinvestment, housing, low income are persistent in the kind of disease and health status you see in different neighborhoods of Boston. Next slide. And you just show all three of these, Rishi. So here is just a visual of what the transportation inequity is like. And on the left is the subway, on the right, on top is the bus stop, and the lower right is a picture of our commuter rail. And actually, we did a project on transportation equity 3 years ago that really helped us understand all the inequities involved in transportation in Boston. I'm going to show you one slide from that, but it was a real learning experience for us and a way of thinking about it differently. What that actually means, inequity. And next slide. So here's a little bit of our data. We led a group of 13 community health centers who surveyed our patients about their experiences in missing their healthcare appointments because of transportation issues, specifically about public transit. And without going into the details of this, what we found out was that people of color take the bus more often, and they miss their appointments more often because of that. But we also found out that the system isn't really working for anybody, for Black, Hispanic, white. They're all really being impacted by missing healthcare appointments because of transportation. Next slide. So here's the second answer that we will come up with, not just a traditional solution, but a more inclusive one. So we have 4 elements in the answer of how do you address a transportation problem with a racial equity framework or racial justice framework. The first one is build an alliance with the patient. So this means expressing to the patient with the transportation problem that we know that the transportation system is not adequate and it's not fair. And this kind of building an alliance is something that we do in another project of ours we've been working on a couple years of a group of docs figuring out how to build this kind of alliance in the exam room by raising the issue of racism and equity. The second part of the solution is exactly the same as the first downstream solution we showed on the front. Solve their problem today or hopefully for the long run. The third element we offer here is for some patients, we can offer them a link to community-based efforts to improve transportation, like in Boston, the T-Riders Union. If this is right for the patient, sometimes this is a really positive thing that can happen as part of our helping them with their transportation problem. And finally, we try to do some policy work as a little piece of every project that we take on. In the area of transportation, we have advocated to get a bus stop moved. We've advocated to impact the way that our transportation authority puts equity into the equation when they decide on their budget. And we've used the survey that we did to advocate for better and more fair transportation. So this is kind of the answer to the second framework in this example. Next slide. So moving on to a broader question of how social determinants of health fits into a racial equity strategy or a strategy informed by understanding structural racism. So we've seen organizations and heard people speak about, yes, we have an equity strategy. Our strategy is asking about social determinants of health, or our strategy is improving diversity. And we see those as important elements to a strategy for racial equity. But this is some of the other elements that we think are important and that we've been working on and Juan Jaime's going to speak in a minute about some of what we've done over the years and what brought us to this. But first important element is understand the history of our country and the whole idea of structural racism, what that really means. And that's something that we're still really learning. The second one is understand how that shows up in our own community and our own organization. And third, it's been important to us to adopt a definition of racism that's common in our organization and embrace the roles that white people and people of color can have in addressing racism. Next, choose ways in our organization to address racism in our hiring, in our policies and procedures, in the way we train our staff, and some of the assumptions that we make as we design programs and content of those programs. And then the last two elements here are ones that are more traditionally thought of. Build a diverse and inclusive organization, and we would say also equitable and multi-identity. And finally, address social determinants of health, and here in the framework of racial equity. Because if we start thinking about diversity and social determinants of health as being the answer to addressing racial equity, we're not really going to have the right framework to build those effectively. Next slide, and Jaime's going to continue.
Thank you, Tom. So a bit about our experience at Southern Jamaica Plain Health Center. Firstly, who we are, we're a hospital licensed community health center, founded more than 40 years ago, and we feel we're part of the great community health center movement in this country. Boston was one of the first places to have a community health center. We're also part of the Brigham and Women's Hospital, which is in turn part of Partners Healthcare, which is the largest multi-hospital healthcare system in Massachusetts. Our population is about 50% Latino. Nearly all our staff speak Spanish, 50% African American, and 35% white. In total, we have about 13,000 patients, 13 PCPs, and 85 total staff. And it's important for us to acknowledge that much of our staff is from our community. So this is work that is very important to us. Our neighborhood, Jamaica Plain, has been gentrifying, but it still has a substantial proportion of immigrants living there. Although many of our patients have been displaced and now come to our health center from other neighborhoods. Our population is mainly from the Dominican Republic, Central America, Puerto Rico, Haiti, and increasingly East Africa and other parts of the world. We're known to be a diverse neighborhood. Unlike the rest of Boston, which for historical reasons remains heavily segregated, Jamaica Plain is known to place people of different identities live and work together. Next slide. So how did we come to our frameworks, this view of structural racism? So our journey began more than 10 years ago. We had began very early on realizing that having a shared glossary of terms is crucial for this work, since there are many ways to understand the words we're using today. We have come to see that racism, by which we mean the David Wellman definition of a system of advantage based on race, is the root of many of the social inequalities of our country. And we see that we've seen the power of always being explicit about assessing racism, but never exclusively, as we need to be intersection about people's multiple identities. When people ask us, what about women? What about LGBT? We say, yes, yes, yes. I mean, we were concerned about Black, lesbian, and gays as well as women and everyone else. It's just a starting point. As we've done this, we've come to see ourselves as a racial justice organization, which means in part that we have to look at how we work with one another and how our patients and our community. And we have done this by building multiple elements of identity as well as our programming. Next slide. Next slide. Oh, it's already there. Elements, got it. Yeah, then okay, I'm lagging, never mind. My screen is running behind. All right, so these elements include our youth programs, which started 10 years ago with groups of young people that were half white and half of color, and thinking about the impact of racism on themselves and working separately with those with the same racial identity and together as a group. We learned from them one thing which is very important, and we emphasize to this day, which is the heart. These issues engender feelings, and dealing with those feelings is crucial to dealing with these problems. We have taken these learnings and generated a popular training that we do on racism and health that we offer to the community. This training has been utilized not just internally, but by many other Boston institutions, other health centers, includes the Department of Public Health and other hospitals. We've done some research and exploration that to see where these themes have taken us. This includes our Adaptive Leaders Program, which Tom referred to, which looks at how this framework impacts how we work in the exam room, and once there, where else we need to think about changing how we look at these things. We've been promoting equity within the Brigham and Partners Healthcare, and have found many other people interested in the work when we do that. We've moved to collaborate with others in influencing public policy, such as youth employment in Boston, sex education in our schools, and transportation, as Tom mentioned. We work across the city government with an organization called GARE, which is a Government Alliance on Race and Equity. Then most recently, we've joined a learning collaborative with the Brigham and Women's Department of Medicine. This learning collaborative is called Pursuing Equity, and it's 8 institutions across the country, the goal of which is to create a change packet for other institutions. So these are places that are already doing the work, and we're trying to gather best practices and have something available to help other institutions get to where we're going. Next slide. So how does all that affect how we collect social determinants of health? Firstly, we're still working on this. This is a process that we've only recently begun with our system to collect this information. But we want to know that we want to start by acknowledging our patients' identities and experiences and aiming to form an alliance with them. I think part of this is focusing not on what they've done, but what's happened to them. As we design and implement these programs, we use these alliances with our patients to help build the programs themselves, to focus on their strengths, and from their participation, get a sense of ownership from the patients and the programs that aim to help them. We've also mentioned that it's important to collaborate with community organizations, particularly those that are invested in systems changes as we are. And then lastly, in the arena of advocacy for policy, we realize that as we begin to do this work, we'll be able to collect important information and data that will be helpful in recommending new policies. Okay, so that's been our journey so far. Over to you, Margot.
Thank you so much. Hi, everyone. Thanks so much for being here today. And I'd especially like to thank Rishi and Tom and Juan Jaime for taking on some of the most challenging areas, not only for healthcare and community health, but really for civil society. As you have heard, I'm a vice president with AcademyHealth, which is a national nonprofit organization based in Washington, D.C. I oversee our work on health IT, delivery system reform, social determinants. I also direct our Center on Diversity, Inclusion, and Minority Health. My personal background is in clinical practice and behavioral medicine, and then I moved over to the health policy side, spent many years on the teaching faculty at a public health school, have a background in public health informatics, and also did a little stint in advocacy for 2 years at the Children's Defense Fund, as well as serving as teaching faculty in health policy and communications. So I come to this with all of those backgrounds. Could I have the next slide, please? For those of you who are not familiar with AcademyHealth, we have about 4,000 individual members, about 180 organizational members. Half are in academic settings, about 20% are in federal and state governments, and the rest are in a variety of nonprofit think tanks and research groups in health systems, industry research organizations, some trade groups. We also have student chapters all over the country. We have a couple of dozen interest groups, including a very active one that focuses on health disparities, which is where a lot of our members are active in their social determinants work. AcademyHealth is best known for its annual research meeting, which draws close to 3,000 people in Seattle at our most recent meeting, and you saw the photograph of Rishi speaking with Bob Ross, which engendered this conversation. We also have an annual health policy meeting, several other meetings, and do a lot of smaller convenings in connection with projects sponsored by federal agencies and foundations on a lot of different health policy topics, including health IT, social determinants, delivery system reform, and best practices for translating research into policy and practice. As you can see on the slide, our mission is to generate evidence and translate that into useful information for policymakers and for clinical audiences. So we're all about being evidence-based and neutral. We did have a group participating as individuals in the March for Science last year, but officially our only advocacy work is on behalf of funding for research, mostly for the Federal Department of Health and Human Services, and to some extent the VA. Could I have the next slide, please? One of my roles is as director of the Center on Diversity, Inclusion, and Minority Engagement, which was created and funded by our board of directors a few years ago as an umbrella for our fellowship and scholarship activities in D&I. At that time, we had a fellowship program for junior investigators sponsored by the Aetna Foundation, and that was discontinued because of a change in priorities a couple of years ago. I'm happy to say that those former fellows are now in leadership roles in various institutions, and one, Dr. Rachel Hardiman at University of Minnesota School of Public Health, is doing some very important work in structural racism with several colleagues. She's also been active in the leadership of our Disparities IG, which is, as I mentioned, the hub of our work on social determinants. So in 2014, we convened about 25 experts in D&I, folks from University of Michigan, diversity officers, Elena Rios from NHMA, members of our board, Hassan Teta, a transplant surgeon and Navy veteran who has multiple appointments, a variety of very talented and thoughtful people for a day of discussions about what AcademyHealth could do to promote workforce diversity and inclusion. And it took several months to distill the conversations into this report, which is available on our website. So this next slide shows what our framework is. These are the recommendations from the report. There were 5 areas. It's kind of a dashboard. So across the top, you can see that there are 5 areas: making a public commitment, communicating clearly about your commitment, collecting data and reporting out to hold yourselves accountable, identifying best practices that are already out in the field, and working on the pipeline. So you can see that most of our activity is in the area of making a public commitment, and that's mostly because we have a lot of public meetings. We also issue a lot of reports, and so we have an internal working group. Our board has regular discussions about equity and diversity and inclusion. We've participated in other conferences and made sure that we have featured people who work in this space in very prominent positions in our conferences. Also, our board met a year after the report was released and met for a full day in person and set some priorities, which are really focusing on the pipeline because even despite our other activities, we feel that that's where our best niche is in terms of the diversity of the future workforce. I can also say kind of anecdotally that our language about D&I has changed since we started this initiative a few years ago, but it still varies quite a bit based on the lived experience of the leadership. We don't use so many euphemisms for racism anymore, like starting with race. We're not talking about white privilege yet, but one of our board members did say that he was tired of going to meetings that look like apartheid South Africa. So some people feel really quite free to express their frustration with this majority culture that represents our organization, even though we are changing. We've been doing pretty well on our dashboard, but once we met up with Rishi after his conversation with Bob Ross at that meeting, we knew that we needed to take our work to another level. So if you look at the next slide, this is kind of a where we are now slide. We've been talking about implicit bias for a year, and we're stuck. That was one of the questions that Rishi framed for you. We're stuck on our next step, so we're working with HealthBegins to figure out how we can promote systemic culture change, not only among ourselves, but among our members and our partners. So why this slide? Some of you might recognize the logo from the HBO series Insecure. The logo is this community organization where the lead character works. The organization is called We Got Y'all, and it has a website in the real world that actually sells these T-shirts, among other products. In the current episode, Issa Rae's the lead character, who's the only person of color employed by this organization, which works with Black and brown kids in the community. The lead character is calling former organizational partners who stopped working with her organization to ask why they left. And the answer she basically gets is that the logo is kind of racist, and they've heard there's only one person of color who works there. So when Issa tells her boss what she's found out, she gets in trouble. I think that's a great example of implicit bias. People who are exhibiting it can't see it. It's not conscious. But it's everywhere in the news, and there's several examples. One example you've probably heard about the finding that was reported by Wired magazine and several other media outlets picked it up about artificial intelligence, that there's racial bias in facial recognition software. The AI training sets feature more white male faces than any other group, so the software can make distinctions with white males better than any other group. And a study done by the ACLU found that the facial recognition software used by Amazon confused mugshots of Black men with 28 members of Congress, including John Lewis. This was in the news about a month ago. And despite this high error rate, police forces are using the software, which has been developed by IBM, Microsoft, and other vendors. And this is just one of many, many examples. But the reason I mention AI is because AcademyHealth has a portfolio working with Health IT with federal contracts and foundations. We sponsor an annual conference with HHS called Health Data Palooza. And those of us who work in this space are trying to keep up with the technical advances around AI in healthcare. This is a huge issue, this implicit bias. And you certainly know about the issues that Silicon Valley has with regard to diversity in its workforce. We've had other examples of implicit bias closer to home, such as a few years ago when we used a freelance photographer at one of our meetings and he only took pictures of white people at the meeting. Another, even despite the fact that there was about 25 or 30% people of color. Another place that implicit bias has been raised is with our Kresge-funded National Interoperability Collaborative, where some researchers from My Brother's Keeper and the Public Health Institute in Berkeley are challenging us to take on the issue of biased research questions in the social determinant space. So this is a snapshot of what AcademyHealth is doing. And on a more personal note, I'd just like to say as a white woman who's married to a Black man that I want to close by acknowledging that today is the anniversary of the death of Emmett Till, who was murdered in Mississippi in 1955 for allegedly speaking to a white woman. Many of you know the story of Emmett Till. If you're not familiar with the story, there are a lot of media stories today about the anniversary And HuffPost has some interviews with young Black men that you might want to take a look at, and how an event that took place in 1955 is resonating with people of color today. So Academy Health is now at a tipping point. We're looking for new directions for the research community and for our other partners. I'm certainly going to look at the training programs that our colleagues from Jamaica Plain talked about. And I know that many of our academic members have diversity initiatives at their own institutions, so we may just start by aggravating other people's guidance that's place-based. But we do have some unique challenges as a kind of a one-off national organization, and we'd like to do much more in collaboration with HealthBegins. So I welcome suggestions from any and all members of the audience and from your colleagues and friends. And I'm delighted to turn back to Rishi to start our Q&A. Thank you.
Margot, thank you so much. And Tom and Juan Jaime, many thanks to you. For everybody who's been listening intently to your presentations, a reminder that the question pane is available for you to start to share your questions with us. Many of you have started to do that already, and we're actively triaging that. In terms of the next steps for this Q&A, we wanted to go back to one of the initial framing questions. Clearly, there are many different conversations and threads of conversations that the presentations today have created, threads that we can continue not just today, but in the future. And that's our primary hope for HealthBegins' role in this collaborative dialogue today. One of the questions, though, that we wanted to explore a little more deeply today was what I presented at the top of the call and has been touched on directly by our presenters. And this is a question now for all of us. With the candor that each of the presenters kind of spoke with, we ask each of us to think with candor and with reflection about how areas of work at our own institutions may or may not be based on a framework that addresses structural racism and equity, that deeper sea of blue against which those other work streams are set against. This is an important question, and I wanted to see if we can activate the audience here, especially as we pivot towards Q&A with our last poll for today. So given what we've heard, wanted to see if we could launch this next poll and ask you to answer. Does your institution, let's go ahead and launch the poll in a second here. Great. Does your institution use a racial equity or racial justice framework? Let's give it about 30 seconds. Great, and please go ahead and answer. And now let's go ahead and close the poll and see what our responses look like. So perhaps the responses are an indication of how either timely our conversation is, or perhaps our conversation today is a little ahead of the curve in terms of where we're at. Nearly 6 in 10 of the attendees today mentioned that to your knowledge, your institutions don't have a racial equity and justice framework. About a quarter are considering adopting a framework at your institution, and others, a minority, cumulatively about 1 in 5, either have and use a racial equity or justice framework and or are partnering with others to implement one. It's an important, I think, baseline, at least in today's conversation, to use as we then go into our Q&A. This is a reminder of some of those framing questions that I presented at the top of the call and want us to all kind of consider. Let me spend just 2 minutes going back to the presenters, and then we'll share the suggestions and the questions from the audience. First, Juan Jaime, to you, you mentioned the work in the exam room as well as the other methods that Southern Jamaica Plain Health Center you've been employing to be able to advance a racial equity framework. Can you speak a little bit more about the work in the exam room? I believe this is called the Liberation in the Exam Room project. I know there's interest both online with questions that have come our way, and I think it's also a good illustration of maybe a way to quote unquote get unstuck.
Sure. So initially at the health center, one of our decisions was to train everybody at the health center on this racial equity framework. And we held a special session for the providers just to sort of, you know, in order to have them together to face these questions. And then they came to us and asked, great. So what do I do? What do I do when I'm seeing a patient? And we realized the answers were really clear. So we gathered together a group of people who were interested in answering that question. And in the very first meeting, one of the participants, who was a resident, said, I just say to them, many of our patients faced racism in healthcare. Are you willing to share some of your experiences about that? And sort of left us all sort of shocked. And that began a series of discussions along how do we spread that and what are people's experience. And then the second phase came up when, as much as that's a great idea, people need tools in order to actually make these changes, because as sort of mentioned in Margot's comments, there's pushback, and people, when they try to make these changes, face a lot of people saying, no, this isn't what we want to do. So the second phase was a year-long process in training individuals to sort of have the framework, have the knowledge, know our history, and have practice. We did pushback circles on what would happen when you say, no, that this policy is racist, or however you would be. How about instead of doing it this way, we do that way? Having both the sort of rhetorical and emotional tools to respond. I want to pause in the emotional part, because this is emotional material. When we did the trainings at a health center, people become very upset. It's about mothers and babies dying. And if we don't include in this work some sort of acknowledgement that people are going to have reactions and they need to have time to sort of process and deal with them, both you as the person understanding it and the person with whom you're speaking and challenging, we found that that's a crucial part of this process.
So I think, Rishi, also to add to that by having a group of docs work on this for 2 years, we've really been trying to build a way of how do you prepare yourself to talk about racism in the exam room, to use it to build a better alliance with the patient, and to make this a part of practice. So we're about to start year 3 on that. It's a complicated question, and we're using a kind of quality improvement methodology, a little PDSAs, yes, and collecting data and trying to, it'll be a long time before we can really figure out impact on patients.
So let me follow this thread here and channel now. I'm going to pivot now to triaging and directing the questions that have come in now from the audience. And for those listening in, please keep them coming. There's a thread of about 4 or 5 different questions that have come across that build off of what Juan Jaime and Tom you spoke to. And Margot, please weigh in on this. And that goes to both the emotional context as well as the change management component of it. So for example, one question was, how do you address the problem of racism in clinical settings where clinicians are, quote, not racist, unquote, and offended by the insinuation that they might be? There's a related set of questions that's one question. There's a related set of questions about, how do you make the case? How do you get buy-in? I think that's probably a reflection of the fact that this is a very emotional conversation that brings in a lot of not just professional considerations, but very deeply personal questions as well for many of us. What are your thoughts about how to engage those who either might have that response and say, well, are you insinuating that I'm racist, and have that kind of pushback, or those who are skeptical about whether this is the right frame to use versus others? Any reflections from either of our representatives today about how to communicate this to those skeptical audiences?
Yeah, this is Tom, and it's a really good point. If we try to, we say lead with racism, and with an analysis that tries to bring racism to the fore, the danger that you have is if people feel like you're calling them racist, then the conversation's kind of over. So we really try to also lead with the data that shows what are the structures out there that are creating bad outcomes for our patients of color, for our communities of color. Make it, the distinction between structural and systemic problems versus interpersonal racism. We really try to lead with that part too, so that we're calling people in to help us work on this problem together. We're not calling them out as racist. And sometimes we fail in trying it that way, and we still get that reaction. But for the most part, trying to lead with the data and talk about the systems is our strategy.
So one other thing that this is part of why it's very important, and this is one of the things we're working on right now as an institution beyond the health center, is to get a glossary of terms and make sure we're all talking about the same thing. When we talk about institutional and structural racism, it doesn't require people to have its action, and that's part of our conversations. We've had issues in the hospital where we've discovered inequities, and immediately people are defensive about, it wasn't me, are you saying I'm racist? I said, no, look, these are the factors. And some people live in the suburbs, some people live in the city, and that's not because it's not random, it's related to historical racial factors.
This is Margot. I'd like to add to that a little bit and think about the concept of teachable moments and what happens in society as a kind of, this is a strategic communications approach, hook the messages that we're talking about to timing in the external environment. So for example, be ready to communicate when something happens, like the Starbucks training. I think the Starbucks training on implicit bias where the stores closed was something that most people in America noticed. And I think that was a moment where a lot of people started talking about, wait a minute, what am I doing? And so to what you heard, the point about systemic racism and structural racism aren't just about individuals. They're about something that's built into U.S. society, but there are also things that individuals can do when there is one of those teachable moments. Speak to someone that you wouldn't normally speak to, acknowledge the issue, start a conversation with people. So there are a lot of little things that you can do to address the issues in a more personal way.
Margaret, to your point about the teachable moments, and then I think to what Juan Jaime had mentioned earlier about, even starting the conversation in the exam room, is that being able to act on those teachable moments, being able to act on institutional racism requires resources, tools, something that people can actually then use rather than just a concept. And I wanted to then use that as a bridge to this other body of questions that has been emerging. And I'll pick one question in particular that's indicative of this other theme now that we're getting in terms of at least half a dozen questions that have come up. This question comes from Chelsea Dade. What resources do you suggest for local state health departments? And I would edit Chelsea's question to expand to other audiences and other healthcare institutions who wish to incorporate health equity and racial equity in their internal work. So let's talk about resources, and I'll actually just move ahead here to reflect back some of the resources that Tom, Juan Jaime, and Margaret, you guys have each shared, including others that may be worth presenting as well, and wonder if you could speak about these or other resources that come to mind that can be helpful for those who are listening in terms of where they can go to start learning about resources they can start to research and incorporate to advance this conversation and maybe even take concrete steps.
Well, a couple of things that come to mind for me is, first of all, for health departments, the Boston Public Health Commission, our own health department, has been working on the issue of structural racism and implementing it into their public health work for many years now. And I think that is a good connection to make for health departments that are interested in exploring how to do that. And also to mention that IHI put out a white paper on pursuing equity in November of 2016. I think you can find that on the internet or on their website, which lays out, really address the fact that all the improvement efforts in healthcare over the last 20 years, that equity has not been at the forefront of that, and they've been trying to do that. The white paper, again, is a good starting point to think about how to divide up the realms of addressing equity in your organization.
This is Margot. A couple of other things come to mind for a kind of a more do-it-yourself approach until you hook up with Boston Public Health Department, which sounds like a great idea. The training video that was done for Starbucks, I'm not remembering the name of the documentarian, but he did a series of interviews with people of color, and that video was released. Maybe I can get the link for you later, or you can just Google the implicit bias training video for Starbucks. What we did at Academy Health was decide that we would use literature, not peer-reviewed publications, but things that are articles that people have read. Like I mentioned, the HuffPost article today on the anniversary of Emmett Till's murder. There are lots of other print articles as well as other kinds of video and training. Diversity.com is a site that has a lot of training materials on it. it's not just for health departments, it's for lots of people. And I think that some of those broader resources can also be really very helpful. And I hope that we're going to have a more informed answer to that question maybe the next time we have this conversation, because that's one of the things that we'd like to start doing.
Yep, absolutely. Well, to extend out the conversation about resources and then pivot over to two other salient questions in our remaining time today, let me underscore what's on this slide here, which is a compilation of some of the resources that have been either directly discussed or alluded to in the presentations. One of the resources, and I believe at Southern Jamaica Plain Health Center, that you guys are actively involved in this, is the Government Alliance on Race and Equity. Over 118 different jurisdictions, municipalities across the country, including based on that map you can see on the slide, are engaged in a variety of different ways to advance, take action, and not just have conversations on race and equity in various ways. It's a great resource. I personally have found a lot of utility out of this, and it also is a helpful resource that is a non-healthcare oriented one. It's about civil intersectoral action, largely place and community-based rather than just from the healthcare perspective. It allows healthcare institutions to see themselves as part of a broader set of actions. We've heard about the liberation of the exam room. There's other steps that I wanted to highlight here. We have various folks who self-identified at the top of the call who are predominantly either in social determinants or diversity and inclusion or in advocacy. One of the key questions that we often challenge our partners and our members at HealthBegins to consider is whether they're actually in seats of power when they're trying to advance social determinants and or diversity or inclusion work. So if you're a champion, for instance, of diversity and inclusion, if you're now motivated to adopt, if not advance, a racial equity framework, the question then is, what's your agency and your institution to be able to make sure that those frameworks and those social determinants of health and or diversity initiatives are being front and center for your organization. Oftentimes the quality improvement committees and other executive sponsored committees are where a lot of the boards and a lot of the bottom line of many organizations often are tied to. And so if you're thinking about ways to advance these frameworks, think about your own role in your own agency, especially in joining committees that may have more direct lines to power. There's also an important element here about increasing training in, I think what has been referenced several times, in structural racism, as distinct from what the current state is, especially in the research space, which is predominantly focused on looking at interpersonal racism and discrimination based on individual racism. And so we know that that's actually a vital area of research, but it's still overly represented compared to the training, the research, the interventions that are available for healthcare to think about how to engage in these questions of institutional and structural racism. So the glossary is definitely required, and then training to build out that glossary is there as well. There's two other so I wanted to highlight those, but there's two other big questions here. One from Madhura Tandale about this question about discrimination and structural equity considerations based on race, but what about other areas of discrimination, such as religious discrimination and gender discrimination? That's one question that I want to pose to you guys, and then a related question, which is how do you measure the effectiveness of a racial equity framework? What are the measures, and how do we know that these frameworks actually can lead to change? So putting those both to you guys in the remaining minutes that we have today, and open to Margot, Juan Jaime, or Tom to answer either one of those.
I sort of, this is on Juan Jaime. I tried to mention that in my comments, but essentially we lead with racism, particularly because of our understanding of the history of this country and the role in which race has played, and the fact that it is something that is being actively suppressed. So we want to lead with that, but we rapidly become intersectional, meaning that we look at the people and all their identities, and we know and we care that about women and everyone else. So we kind of talk about the most disadvantaged person in all of Boston is a trans Black woman in Mattapan. Any system that we design to help her will help everyone else. So that's kind of the model we use. We want to be inclusive in our efforts.
Yep.
And
Juan, thank you so much for that. And Margot, do you want to take on any quick thoughts on the, in the maybe 10 seconds, 15 seconds left, about the other consideration of measurement frameworks? Is this an area that's being developed or still needs further development?
No, thanks. I'll cede my time back to you, Rishi.
Okay, I think the answer to that question is certainly that there's some demonstration of effectiveness of these types of frameworks based on the data that Tom, I think, spoke to earlier, but more work needs to be done. This is such a rich conversation, and we're at the end of our time today. There's a lot of questions about tools, and so what we encourage everybody who's still on the line to do is to take the follow-up question survey that will come out right after this. It'll also come to your email inbox. We'll ask you not only about what you thought of this webinar, but more importantly about any other questions you have or ideas you have, including specific resources or tools that you found helpful to advance a racial equity and racial justice framework in your institutions. We'll ask you for suggestions if you want to share your work, your experiences and insights with other peers in healthcare as well. So please stay engaged, take the follow-up survey. This is one in a series of conversations that we at HealthBegins, along with the partners at AcademyHealth, Southern Jamaica Plain Health Center, and many of you hope to engage in. This is the beginning and not an end of, I think, a vital conversation. Thank you all for joining us today, especially to our presenters, Margot, Juan Jaime, Tom. Really, it's been a privilege, and we're looking forward to the next conversation soon.
Thank you.
Thank you all.